thrilled to not have a drug dealer here today, but the real thing. So give a welcome to Brad Moore.
Yeah, so the better question for most of my patients is, where do you get your fiber? So thank you, Gwen. It's just been great to see all the great things you're doing out here at GreenFare, and I'm just excited to be able to come and be part of that and share what we're doing at GW. So Gwen asked me this morning, she sent me a text, are you going to have slides or are you just going to talk? And I've been a professor for 30 years, so you're stuck with slides. And you're also stuck with learning objectives. So what I hope you'll walk away today knowing is understanding a little bit more about the burden of chronic disease in the US and why our current approach to that isn't working. We'll define the discipline of lifestyle medicine and hopefully demonstrate another approach. I want you to understand what it takes to make meaningful lifestyle change, and I want to share a little bit about what we're doing at GW. So, and along the way, you'll learn a little bit about my story. So I graduated from medical school in 1989. I finished my training in 1995. And the world that I emerged into to practice was one that was really dominated by chronic disease. And that's really the big pandemic in the US. It's not COVID. That was a distraction, but this is what's killing more people in the US than anything else. You know, 5 in 10 Americans have a chronic disease. 4 in 10 have 2 or more chronic diseases. We've got epidemics of obesity, high blood pressure, heart disease is still the #1 killer, and really no end in sight. So when I came to GW, I started, when I came to DC, I came to GW, and this is the George Washington University Medical Center. The medical school is celebrating its 200th year this year, and we have a hospital, a medical school, and a big outpatient practice. So when I came to GW, I trained in Philadelphia at Hahnemann University, which is now Drexel, and I came to GW to do an academic primary care fellowship and got a master's in public health. And for the next 20 or so years, I practiced evidence-based internal medicine, taking care of patients with high blood pressure, heart disease, diabetes, arthritis, and you know, we provided really good evidence-based care. During this time, I had some significant stresses in my own life, and that led me to be 20 pounds overweight. I was feeling anxious and depressed. And my first personal lesson about lifestyle medicine came from exercise. I had never really been an exerciser. I was an asthmatic, bad asthmatic when I was a kid, so I couldn't exercise. And I tried different things. I tried running, but always got injured. And finally, in my 50s, I started forefoot running, not heel striking, and I actually found I could run without injury. And it was a great way to deal with stress. It helped with weight. And it changed the way I thought about myself. I was a runner, which was something I never thought I would say. In fact, for a long time, I said I would run only if chased. But it got to the point where I needed to run. It was just, it really was transformative for me. And so I started thinking about lifestyle medicine by wanting to share that with my patients. And so, you know, being trained in internal medicine and having a degree in public health, I was always thinking about prevention. But early in my career, that really just meant early detection of disease. Like most physicians, I believe that lifestyle was important, but I also believe that most patients weren't really going to make a change, and that genetics was kind of destiny anyway. And so I focused on, you know, the traditional pills and surgery, and this is what my practice looked like. I didn't have a lot of people who were changing their lifestyle because, you know, the way I communicated that need to them was almost in passing after I'd written a prescription for a blood pressure medicine saying, well, you really should exercise more and eat a healthier diet. What's a patient supposed to do with that? That's really not actionable information. And it took me a long time to figure that out. I was completely wrong about the genetics thing, but it took me too long to figure that out as well. So this cartoon, which is attributed to Dean Ornish, is an illustration of how traditional medicine thinks about chronic disease. It's this analogy of a clogged, overflowing sink with the faucet still running. And when doctors see this, we're trained to just get a mop and mop the floor. In other words, when a patient comes in with high blood pressure, we prescribe medication. They're diagnosed with high cholesterol, they get a statin. Their A1C goes up, we give them metformin. And all these drugs will lower the overall risk of heart disease, stroke, and death, but at a point in human history, when we have more drugs than ever, we still have more chronic disease than ever, and heart disease is still the #1 cause of death. So we end up giving patients medicine, and then we give them more medicine, and then we give them medicine to treat the side effects of the medicine we're giving them, and it's really not sustainable. Well, why do we approach chronic disease this way? Well, we're trained in a system that I think, unfortunately, is heavily influenced by the pharmaceutical industry. We give medication, we do procedures to treat the symptoms or consequences of chronic disease, which is overwhelmingly due to lifestyle. The current reality is that we now know that genetics is not destiny, and that the exceptionally powerful epigenetic effect determines 80% of gene expression, and lifestyle choices control that gene expression. So pills aren't the solution to the healthcare crisis. They're like mopping the floor rather than getting to the source of the problem and either turning off the faucet or unclogging the sink. And how does it feel to practice like that? It feels like you're playing whack-a-mole. It's pretty frustrating, really. It's pretty discouraging. Even though we were treating patients with the best evidence-based standards, they very seldom got better. And I started to wonder, are medicines as safe as we think? And when I read about it, I looked and found this quote by William Osler, who is the father of internal medicine. The person who takes medicine must recover twice, once from the disease and once from the medicine. Now, in his time, medicines really were toxic, but I still think there's some truth in that saying, and I want to give you some examples. And I just want to be clear that I am not saying that medicine doesn't have its place. It absolutely does, but I think we tend to put so much faith in medicine that we overestimate what it can do for us, and we really underestimate the power of lifestyle. So I wanted to show you two examples. This is an example about statins. So the Mayo Clinic has a great decision aid for patients who want to see the effect of statin in their own life. So you can go to the link there and plug in your own data. But what I plugged in was, what is the risk of a 50-year-old white male non-smoker who has well-controlled high blood pressure with a systolic, that means top number, blood pressure of 130, a total cholesterol of 260, and an HDL of 40. So if you look on the left side here, you can see that his current risk of having a heart attack, so for 100 people like you who don't medicate for heart problems, over 10 years, 8 people will have a heart attack, and 92 will have no heart attack. Okay, so the risk is significant, but the standard approach that I would have taken when I was practicing just internal medicine, not with a lifestyle approach, is to give a statin. And statin does decrease the risk. Over here it shows the risk for 100 people who are taking standard dose statins. And so 2 fewer people will have a heart attack, and 92 people will have no heart attack. So there is an effect, and if you look at, the effect in relative terms, that's, that can be pretty significant. But there are also patients who have side effects. 5 in 100 patients will have muscle stiffness. 2 in 100 patients will have liver abnormalities, and 1 in 20,000 patients will have significant kidney damage. So what I take away from this is not that statins are harmful. They can be very helpful, but they aren't the panacea that say you can go to Bob Evans and have, the giant breakfast with impunity. They are decreasing your risk, but not as much as everybody thinks. High blood pressure medicines are another example, and this shows the number needed to treat to get some benefit. That's what NNT stands for. So if you give patients antihypertensives or blood pressure medicines, there are benefits. 1 in 125, you prevent a death. So you have to give 125 people blood pressure medicine to prevent 1 death. 1 in 67, you prevent a stroke. 1 in 100, you prevent a heart attack. But you also have to look at the harms, and 1 in 10 were harmed by side effects of the drugs to the point that they stopped taking the medicine. So again, I'm not saying that blood pressure medicines aren't important, but they aren't the magic pills that I think the pharmaceutical industry would have us believe. So when I started noticing this, I went to the American College of Preventive Medicine annual meeting, and I heard a talk from this guy. Some of you may know him, Michael Greger. He's one of the founders of the discipline of lifestyle medicine, and he gave, in his own unique style, a really dynamic talk about how if you optimize your diet, you can you can prevent chronic disease, you can improve the symptoms of chronic disease, and you can even reverse chronic disease. And I came away from that talk, I wish I could say that I came away from that talk completely converted. The scales fell from my eyes. Unfortunately, I came away from that talk thinking he was some sort of a snake oil salesman, How could I have been practicing medicine at an academic institution for 20 years and not know this if it were true, right? So, but because I'm in academic medicine, I responded to this by digging into the literature. And I started looking at the actual studies, and I found that not only was he true, there was what he was saying true, there was really a tremendous amount of literature out there to support it. And I started looking at the actual causes of death in the United States. The number 1 cause of death that you'll see is heart disease, number 2 is cancer, number 3 is stroke. And in 2000, the actual cause of death underlying that was tobacco, number 2 was poor diet and physical inactivity. I'm proud to say that our efforts to get people to quit smoking have changed it so that tobacco is number 2, and now poor diet and physical inactivity is the leading actual cause of death in the United States. So I thought there had to be another way. And I started thinking, how can I begin to apply what I've learned from Dr. Greger and Dr. Barnard and reading the literature and Dr. Furman? How can I apply this with my own patients? And so I started trying just a little bit with selected patients, and I want to tell you about one of those patients. So MW was a 38-year-old male who came to me, and this is going to feel a little bit like a medical school presentation, so bear with me. 38-year-old male with a past medical history of high blood pressure, high cholesterol, hepatic steatosis, which is fatty infiltration of the liver, gastrointestinal reflux disease, so heartburn, obesity, asthma, and anxiety. And he was coming to me because he had just been diagnosed with type 2 diabetes. He said that he felt lethargic, he was irritable all the time, he didn't sleep well, he woke up sweating in the middle of the night. And his diet was the standard American diet. And he actually said to me in that first meeting, I would die before I give up eating meat. And he was sedentary. He was on atorvastatin, which is for cholesterol. He was on lisinopril and hydrochlorothiazide for his blood pressure. He was on sertraline for depression and lorazepam for anxiety. And he hadn't been started on diabetes meds. He was 210 pounds. His BMI was 33. His blood pressure on medicines was well controlled. His hemoglobin A1C, which is a measure of sort of average blood sugar over 3 months, was 12.7. And to give you some perspective, a normal person, it's below 5.6. When you're over 6.5, you have a diagnosis of diabetes. And the goal, if you have diabetes, is to get it somewhere down around 7 or 8. So he was way up there. And his total cholesterol was 169, and his LDL cholesterol, which is the one that increases cardiovascular risk and should be under 100, was 112. So I told him he was at a decision point. I said, you know, the way I would have treated you for the past 20 years of my career is I would have said, you now have type 2 diabetes. You're going to have that for the rest of your life. So what we need to do is we need to decrease the carbohydrates in your diet, and we need to give you some medicine so that we can lower your blood sugar. And if we look down the road, you know, the first medicine will work for a while, and we'll probably end up adding a second medicine. But don't worry, we can control this. We can decrease it so that you don't have blindness and you don't develop kidney disease. And I said, but I've recently learned about another approach, and that gets at the actual cause of your type 2 diabetes. We know now that type 2 diabetes is caused by insulin resistance, meaning that the insulin your body is making doesn't work. And we know what causes that. It's fat inside the muscle cell, specifically saturated fat. So there is evidence that if you can change your diet, the fat will come out of the muscle cell, the insulin will start to work. If you can exercise and build more muscle and use your muscles, you'll be more effective at getting the blood sugar out of the blood. And not only can we control your type 2 diabetes, we might be able to make it go away. Which option sounds better to you? And he picked the lifestyle option. So what we did was we met about once a month, and I'll show you, this is the intervention that we followed with him. Initially, we advocated a whole food plant-based diet, and we'll talk about what that is. It's basically an unprocessed plant-based diet. Over time, we added in some time-restricted eating to help with weight loss. For movement, we initially said, you know, just walk 10 or 15 minutes after you take in a meal to get your blood sugar down and increase your non-exercise physical activity. And our later goal was to get him up to kind of what the recommended guidelines say. For resilience and managing his stress and sleep, we recommended exercising for stress management, sleeping 7 to 9 hours a night, and we recommended that he engage the support of his family and friends. So rather than giving him medicine, after a month or two, we had to start taking away medicine. It's called medicine deprescribing. So we were able to lower his atorvastatin dose from 40 milligrams, this is for his cholesterol, to 10 milligrams. He didn't need the anti-anxiety medicine anymore. His antidepressants stayed the same, and his blood pressure medicine stayed the same. But this is where his biometric parameters went. He lost weight. His blood pressure was actually lower, even though he was still on blood pressure medicine. His A1C went from 12.7, which is really high, to 5.5, which is no longer diabetic, in 6 months without medicine. His cholesterol was better on less medicine. And so overall, he lost 16 pounds. His systolic blood pressure, the top number, went down 14. His cholesterol went down almost 60 points. His type 2 diabetes was reversed. His liver inflammation improved. His heartburn that was waking up at night went away. His anxiety improved, his sleep increased, and his energy level improved. And I asked him how he felt, and he said, I feel like I'm living more. He was able to be more active with his kids, more engaged with his wife, and less irritable. And all of this by just changing his lifestyle. And I showed you the slide of me of banging my head against the wall and playing whack-a-mole, and how stressful that was, and how that's a road to burnout. This was exhilarating. I mean, this doesn't happen in internal medicine, right? Patients don't get better. And this was incredible. And it was all due to lifestyle medicine. And I just want to tell you a little bit about the discipline of lifestyle medicine. So, and I want to start by just sharing this study. Less than 3% of Americans live a healthy lifestyle. And this is a study that was done at the Mayo Clinic. They had a sample of almost 5,000 people, and they found that less than 3% of Americans were living a healthy lifestyle if you define it by these 4 qualifications. Moderate or vigorous exercise for at least 150 minutes a week, a diet score in the top 40% of the healthy eating index, body fat percentage under 20, and not smoking. So, lifestyle medicine is kind of a response to that. And it's defined as the use of a whole food, plant-predominant diet, regular physical activity, restorative sleep, stress management, avoidance of excessive risky substances like tobacco or alcohol, and having positive social connections in order to not only treat, but reverse chronic disease. So it's simple, powerful therapy, these 4 things, or 6 things: nutrition, sleep, exercise, limiting substance use, managing stress, and being socially connected. And I want to just take you through some of these and show what the benefits are. So I always start with sleep because it's really the foundation of good health. It's something that we tend, especially in Washington, to minimize. When I first came to town, it was a badge of honor to not sleep. But the benefits of adequate sleep are incredible. It lowers blood pressure. It helps the immune system. One of my favorite studies to illustrate this looked at people who got the flu shot and looked at their antibody response. And people who were underslept, meaning less than 6 hours sleep a night the week before, had a 50% lower antibody response. And your immune system doesn't only protect you from viruses and bacteria, it's how your body fights off cancer. So having a fully functioning immune system that's really working at the top of its game is really important. And one of the most important things to ensure that is good sleep. Decreased heart disease risk. Another fun fact is that the night, if you look at the whole US population, the day where there are more heart attacks than any other is the day that we lose an hour when we shift our clocks ahead. Just that 1 hour of decreased sleep, when you multiply it across the population of the entire country, leads to, or at least is correlated with, more heart attacks. It's one of the 3 things that's most important for decreasing dementia risk, along with physical activity and eating a plant-predominant diet. People cope better if they're well slept, and a nice side effect is a healthier weight. We know that if you get under 7 hours sleep a night, you tend to eat an additional 600 or 700 more calories the next day, and you tend to crave kind of unhealthy, sweet and sugary and fat calories. I'm not going to say a lot about avoiding harmful substances. I just want to show that there are still a lot of tobacco-related deaths in the world. The health effects of smoking really extend well beyond lung cancer. There are a number of other cancers on the left there that are related to smoking. It directly increases heart disease risk and blood pressure, fertility, a whole range of things. And we should just talk for a minute about alcohol. Most of my career, I've been saying, if men have less than 14 drinks a week and women have less than 7, no problem. There was even, a thinking for a while that a little bit of alcohol was good and it lowers risk. And a lot of research has been done over the last 20 years, and it's really now clear that there are no health benefits from alcohol. Risk goes up from 1 drink. It's not huge. I'm not telling people not to have a drink, but people need to know that it's not helping their health. It's just increasing their risk. Exercise. I love this quote: "The current human genome requires and expects us to be highly physically active for normal functioning." Our genome hasn't changed that much in the last 100,000 years, but how we move and how we interact with our environment has changed tremendously. And that means that our gene expression isn't functioning the way it should. So what should we be doing? The CDC guidelines are 150 minutes a week of moderate physical exercise, and that can just be brisk walking, or 75 minutes a week of vigorous aerobic exercise like running or something along those lines, cycling, plus, and this often gets forgotten, 2 sessions a week of some form of strength training. And they don't need to be long, 30 minutes twice a week. That involves most major muscle groups. Basically, think about it as pushing and pulling upper and lower body. So that's the goal. How are we doing? Well, really not so well. The 18 to 24-year-old age group tops out. They're the very best, and 33% of men are meeting those guidelines, but it's all downhill from there. In general, we're about around the 20% level across the age group. Let's just dive a little deeper into the benefits of exercise. And there are benefits not only for physical health, but for mental health. Helps prevent cardiac disease that we talked about and stroke, reduces blood pressure, controls blood sugar, controls weight and helps prevent obesity, helps prevent bone loss and osteoporosis, strengthens the immune system. From a mental health standpoint, it improves sleep, it increases interest in sex, it provides stress relief, it can increase self-esteem, it improves mood. There was a head-to-head study with Prozac, which is an SSRI that's used to treat mood disorders like anxiety and depression, versus exercise. And they both work, but exercise works in more people. And whereas SSRIs like Prozac take 6 weeks to work, exercise works in a couple of days. So when I talk to my patients who are dealing with anxiety and stress and depression, I tell them to think about the dose of their exercise, because it really is like a drug. It works better than the drugs. Increased energy and stamina and reduced tiredness, and can improve mental alertness. So there are a lot of benefits. We're doing not very well, but we don't really need to do a lot to make a big difference. If you look at this curve, this is hazard ratio of mortality, and this is leisure time physical activity in something called med hours per week. So that takes into account how intense the exercise is and how often they're doing it. And so this is no exercise at all, and this is that 150 minutes a week of physical activity. But what you notice here is that just doing something is where the biggest benefit comes, and that, you know, once you get above 300 minutes of moderate physical activity, there's not a lot of additional benefit. But the biggest benefit comes from doing nothing to doing something. And it doesn't have to be exercise. This is a Venn diagram that shows, you know, the big circle of movement. Within that is a smaller circle of physical activity, which is things that you do in your life throughout the day. And then exercise is really just deliberate physical activity. But you can get this benefit, this decrease in mortality, just by moving, just by being physically active. So things like taking the stairs, parking at the far end of the parking lot and walking a little bit, bicycling to work. I think it's actually really great to try to find a way to put movement into your commute, because it's something you do every day and you can't say I don't have time for it. You just have to do it. Walking your dog, raking leaves, even vacuuming around the house and yard work. Those all make a difference. So we talked about sleep, we talked about avoiding harmful substances, we talked about physical activity, and the big one that we haven't talked about yet is nutrition. And from the standpoint of lifestyle medicine, we recommend choosing a predominantly whole plant-based foods that are fiber-filled and nutrient-dense. But again, we're not doing very well. 75% of Americans say they eat healthy, but more than 80% of Americans fail to eat the recommended amounts of fruits and vegetables. What are we eating? The standard American diet. And that's really kind of sad. So when you look at this, the biggest part of this pie, 63% of the standard American diets are processed and ultra-processed foods. 25% animal products, and then only 12% of fruits, vegetables, whole grains, beans, and legumes. But diet is the leading cause of chronic disease and disability. And the most important dietary risks in the United States are diets that are low in fruits, low in nuts and seeds, high in sodium, high in processed meats, low in vegetables, and high in trans fats. That's what's driving this. There are a lot of problems with animal-based diets. They elevate cholesterol levels, they promote insulin resistance, they actually increase the likelihood of osteoporosis, they promote cancer, they're pro-inflammatory, and a lot of that is because they're so high in saturated fat. Whereas on the other hand, whole food plant-based diets are anti-inflammatory, they reduce total body weight, they're good for the environment, they're low in saturated fat, and they can be used to prevent, treat, and reverse a lot of these chronic diseases. I think if you're eating here, you know what a whole food plant predominant diet is, but it's legumes, nuts, seeds, whole grains, fruits and vegetables, and a plate that should look like this. And what's missing here is meat and dairy, because you don't need those for protein. So let's compare that diet to the standard American diet from a standpoint of nutrient composition. So plant-based diets have no cholesterol. They're much lower in fat. They can be comparable in protein, but they're where all the fiber is. And we know that fiber is how we feed our intestinal microbiome, which is important for many, many more metabolic processes than we realize. And there's no fiber in any animal product. fibers only found in plants. And if you start looking at micronutrients, you're doing a lot better with plant-based diets. Notice I didn't say vegan diet. These are examples of a vegan diet. French fries, Pepsi, Oreos, and the Impossible Burger. Vegan diet means good for an animal, good if you're an animal, good for the planet, but not necessarily good for you. And unfortunately, the food industry has realized that if they put the word vegan on something, they'll sell it to people. Vegan's not a bad word, it's just a word that's being misused. And there are a lot of things that are labeled vegan that are not healthy. And so that's why we talk about a whole food or an unprocessed plant predominant diet. Michael Pollan very succinctly said, if it came from a plant, eat it. If it was made in a plant, don't. I think that's a good advice. And we know that the longest lived peoples in the world, we know from Dan Buettner's work and the Blue Zones, eat meat, but only as a condiment or a celebration, and nothing they eat has a plastic wrapper. And they tend to eat whole grains. Almost all of them have beans or legumes as a big part of their diet. And so food is medicine. If a poor diet caused the problem, a healthy diet can correct the problem. So what began as an interest for me when I saw how it affects my own patients became a passion. And over time, it became something that I really thought needed to be the foundation of what we did to take care of patients. And I started thinking about, why don't more patients do this? Because, you know, we tell them that standard American diet, processed food, is bad. We tell them that you need to get saturated fat out of your diet, but so few of them are able to make the change. And, you know, I think the unfortunate tendency in medicine is that we assume that they just weren't trying hard enough. And I think what it means is that we weren't trying hard enough. I think it's on us as physicians for thinking that just by giving them this connection, that's going to solve everything. There's no question that patients need the knowledge to be able to make a choice. Patients need to hear that lifestyle modification works. Not every patient will choose to do it, but every patient deserves to understand that if they do it, it can be meaningful and impactful for them. But having that knowledge and making that connection is really just the first step. It's not enough to really make meaningful lifestyle change. What you need to make meaningful lifestyle change is really threefold. You need the knowledge of what change would be impactful for you. You need to be motivated. You need to have the right attitude. And that's different for everybody. But what we need to do as physicians, if we want patients to do this, is help them find their motivation. But in a sense, those are the easy things, right? If you come and tell me, I don't want to have to be on diabetes medicine, and I tell you, okay, you need to get saturated fat out of your diet, we can do that in one visit. But that's really just the beginning. The hard part is figuring out, how do I practically make a difference? How do I practically change the way I've been eating and living my life for the past 40 years and do something different? And if we really want people to make meaningful change, we need to help them find those tools and stay with them as they make the change. And so as I started thinking about, how can I do this in my own practice? And because modern medicine gives us, 20-minute visits, we can't do all of that in 20 minutes. We came up with the idea of creating resources online to support patients as they make change. And so I want to share with you some of the resources that we have on our GWU website. These are open to all patients. You don't have to be part of our practice. Any of you can use these as well. So if you can scan the QR code on the poster there, and I'll have a QR code at the end of the talk you can scan that'll take you right to this web page. But if you just Google GW Lifestyle Medicine, it's the first thing that comes up. We are building resources to support each of the 6 domains of lifestyle medicine. We have currently healthy eating, physical activity, sleep, and avoidance of harmful substances, with hopefully in the next 6 to 8 months, all of them coming online. And I'll show you some of the resources that are there. So first, let's look at healthy eating. And we talk about what America eats, what the standard American diet looks like, and what a whole food plant predominant diet would look like. Here's the view from 20,000 feet of what you should eat more of and what you should avoid. This was sort of version 1, and we thought, okay, well, we're showing everybody that, no problem. But I kept hearing, well, when I go to the grocery store, what can I actually buy? And so we partnered with Instacart to create the GW Lifestyle Medicine Shop. And so if you click on that gray button, it'll take you to Instacart. And you can point this to any grocery store that you want. I shop at Giant, so this is Giant. But the only things that it's going to show you if you enter Instacart through this portal are whole food plant-based choices. So you can use it just to see, what's available as you plan your list, or you can actually order and have it delivered.
Blueberries and dark chocolate.
Both good things. And then we have a lot of other resources as well. So we have a bunch of handouts. There are websites, videos. The Forks Over Knives, if you haven't seen the Forks Over Knives documentary, that's available free, and you can stream it from their website, and we have a link to that. A curated list of cookbooks and books supporting a plant-based lifestyle. Even a good link to plant-based cooking lessons that are available through an online culinary school called Ruby. We found that there's a tremendous amount of really good information out on the web, but there's also a lot of really bad, misleading information as well, and it's hard even for educated people to tell the difference. So we wanted to provide a curated list of resources that are all evidence-based for each of these areas of lifestyle medicine. So this is just some of the videos that are available. We have a section on sleep that talks about the importance of sleep. It has some tools to help you assess how well you're sleeping and uncover what some of the problems are. Screening tool for sleep apnea, recommendations what to do if you think you have it, as well as some very good and interesting videos on how to optimize your sleep habits so that you have more restful sleep. We have a section on avoiding harmful substances and helping, if you click on the buttons at the bottom there, resources to help people who want to quit smoking or who want to cut back or quit drinking. And I'm very excited to share our latest thing that was really only been up for about not even a month yet, our physical activity section. So this goes into why we should care about physical activity. It has resources to meet you wherever you are. If you're wheelchair bound and not moving, it has resources to help with movement. If you're already an athlete but really want to optimize and find out how to optimize your VO2 max and your body composition, we have tools to help with that as well. So, after improving my own life with lifestyle and seeing what it could do for my patients, I really came to think that lifestyle really has to be the foundation of how we care for patients. And my vision for GW is that it's a place that provides, tertiary and quaternary high-tech care, but everybody who comes to GW will also talk to you about your lifestyle, because that's got to be part of how you take ownership for your health and sustain good health going forward. So we're not there yet, but we're working on it. We do have a clinic 2 half-days a week where patients can come with chronic disease and learn how to change their lifestyle, and we educate and support patients through that. And we realized that in order to really make change not only at our institution, but in medicine writ large, we needed to start training doctors differently. And so we started a lifestyle medicine pathway within our internal medicine residency. Residency is after you graduate from medical school and you want to specialize, you do a residency. It's usually 3 to 5 years. Residents who are becoming trained in internal medicine can choose to also do a lifestyle medicine pathway where they learn about lifestyle medicine and can become board certified in both lifestyle medicine and internal medicine when they finish. The unfortunate reality is that in medical school, there isn't a lot of nutrition being taught, and most of it that is taught is about nutritional deficiencies like scurvy from not enough vitamin C or rickets from not enough vitamin D. And, we don't really see a lot of that. I've never seen scurvy or rickets in my, 30-year career. We don't have diseases of nutritional deficiency. We have diseases of nutritional excess, and we aren't teaching about that. And so this curriculum does teach about that. It has a 100-hour educational component, 40 hours of didactic units on exercise, sleep, physical activity, all of the pillars of lifestyle medicine, 60 hours of applying those. So, learning culinary medicine techniques, how to cook healthy and teach how to cook healthy, learning how to, in your own life and with your patients, improve sleep and physical activity. They have to document 400 separate patient encounters over the course of 3 years where they talked about lifestyle. They get some experience in group facilitation and also in more intensive therapeutic lifestyle change programs. I'm excited to say that the program started in September 2022. We have 48 residents, fellows, and faculty involved in some part of the program. For the last 2 years, the incoming class of interns, they had to apply if they wanted to participate, and both years, about half of the incoming class applied and were accepted into the program. So this next generation of doctors really does get this, and I'm very optimistic that that over time we will really start to change the way medicine is practiced. I want to just tell you a little bit briefly about lifestyle medicine research at GW. We just finished collecting data on hand grip strength as a motivator for patients to do more resistance training. What we found is that most of our patients who exercise do cardio, and people are less likely to think about strength training. And most people, if you ask them, are you strong, average, or weak, they'll say they're strong or average. But when you actually test them, not everybody is as strong as they think they are. So we haven't analyzed the data yet, but we're looking to see, if understanding how strong you really are will motivate you to make some form of strength training part of your routine. And the reason for that is, strength is related to building muscle. Not having enough muscle, sarcopenia, leads to insulin resistance, it leads to frailty, it leads to falls. And so there are a lot of consequences to not being physically active. But even just doing a series of 4 exercises can make a difference. Doing squats, push-ups, lunges, and rows our working upper and lower body, pushing and pulling movements doesn't need to be, super complicated. We're also looking at the microbiome. This is an abstract that was just presented this week, looking at how much patients know about the microbiome and whether or not a little educational tool that we developed would have them change their diet. What we found out was that patients know more about the microbiome than we thought, but we also found out that physicians don't generally talk to the patients about the microbiome and how to optimize their microbiome. And so there's a lot of room for improvement there. And we're in the process of designing a study looking at physical activity and the effects of physical activity on the microbiome. We know that there's a lot of data already on the effects of diet in the microbiome, but less on the effects of physical activity in the microbiome. So we're going to be exploring that. So I told you a little about my journey in lifestyle medicine, and I hope that it's inspired some of you to explore your own journey. This is the link to the GWU website. We have all of our resources. You can scan the QR code. And I would say, if you do nothing else, when you leave today, think about the lifestyle choices you make in your life. And this is, about sleep and exercise and movement and diet. And everything that you choose to do is either helping you and leading you toward a life free of chronic disease, or it's leading you down the path toward chronic disease. And it doesn't matter, what weight you're at, you can still make those choices to choose healthy choices. So as much as possible, focus on making as many positive choices as you can. Try adopting the mindset that every choice is either promoting health and nourishing your body or leading toward chronic disease. And when it comes to fruits, vegetables, beans, and whole grains, variety is the path to good health, as well as the spice of life. So when you're choosing those foods, eat the rainbow.